Hello everybody, this is Dr. Bennett. I'm going to spend a little bit of time talking with you today about really the medical interview and what we're terming the hypothesis-based reasoning, which really what we're talking about is that initial encounter with your patients. How are you developing the ideas in your head and your clinical reasoning of how to treat them and what we're going to do first? One of my favorite quotes comes from Hippocrates when he's speaking to his medical class. It's the paragraph right before where the Hippocratic Oath is taken from, but perhaps it's one that's often overlooked. Hippocrates says, "Be still, young physician. Your patient is telling you the cure." Again, in other words, if you just take time and listen, our patients can give us information that helps us identify how and really what we need to do to treat. Perhaps in a little less eloquent way, my grandmother in her blue jeans and sweet tea wisdom says, "Bud, just shut up and listen." And I think that's sage advice. So what is the hypothesis-based reasoning? Well, let's break it down. We talk about using a structured questioning strategy to formulate a hypothesis, which we then go into the physical exam to either prove or disprove, which ultimately guides the first choice of intervention, allows us to get there quickly, right? Because at the end of the day, we need to be accurate, but efficiency plays a very important role. For example, nuts to bolts here, we can take body charts like this. Now this is a real body chart, but this is not the actual picture of the young lady that we saw. But these are her actual comments, where you can take body charts like this and really hone in and make large changes fairly rapidly. Alright, well let's talk about a little bit of why we use this particular process. Well, it's a checklist, right? I mean, we use an organized and efficient process-driven model, meaning that there are specific things along the way that you'll be required to check off as you go through. Again, we use a checklist, kind of an asked and answered approach, similar to what you might find in the cockpit of an airplane. The co-pilot might ask the pilot, "Did you raise the landing gear?" The pilot says, "Check." Did you adjust the trim? Check. And so again, it's an asked and answered process, very similar to what you might see there. Purpose of this is so that nothing is overlooked as we're taking these patients through this particular exam. So ultimately, we're trying to create a rockin' medical interview. Here are some of the reasons in terms of bullet points on why we want to create this medical interview process. But ultimately, what we're looking for is your hypothesis will give you a primary thought. In other words, a primary hypothesis. Again, you may have some competing hypotheses. For example, you might have a primary hypothesis of low back pain caused by something mechanical within the lumbar spine, or at least that's what you're thinking. But your competing hypotheses may be, that you need to rule out something coming from the hip. So again, it gives us this ability to plan our objective exam using known test properties to rule out competing hypotheses and ultimately ruling in our primary hypothesis. And this is confirmed by seeing the expected changes within treatment sessions. So again, a focused medical interview will allow us to move quickly into intervention. It's nice to zero in on that target. It allows us to sort of make our best first strike. But sometimes we're not able to really isolate that target. And for those of you who may be a little bit like me, we're a little less equipped and need a little bit more training. Sometimes we fall back on sort of just lobbing a grenade. What I mean by that is a grenade is not a very specific weapon, is it? It just sort of scatters and goes everywhere. With the hypothesis-based reasoning, in the event that we're not able to identify a clear, accurate direction, we can narrow down that direction substantially And what I mean by lobbing a grenade is that we can initiate a treatment towards our hypothesis. Sort of when the smoke clears from that first level of intervention, we're often better able to make the next logical step. So again, it can be very, very helpful. So let's go through some of the specifics of what a hypothesis-based reasoning exam will look like. We're going to use this case study format. This is a PowerPoint that you will have access to, and the accompanying medical screening form. So you'll all have copies of those. Those will be loaded onto the platform here for you. I'm going to adjust my screen a little bit because this is actually the same PowerPoint that you have, and there are some places in this that you'll see that we have notes written down in here for you. So let's go into the first slide of the medical screening questionnaire. I tend to ask that you use some red color or bright blue color again, so we can kind of see where your information is as opposed to the background or format of the slide. This part of this slide, or this particular slide, is perhaps one of the most important. We talk about clearing the body chart. So if you look, every single one of the pain areas is labeled. So here I have a P1, here is a P2. If you notice that each pain region has a patient descriptor. Is it a sharp pain, a dull pain, an ache, a throbbing, etc.? And then we're looking at, is it intermittent or constant? In other words, does it come and go, or is there something always there? And then is it variable or is it consistent? Variable would indicate that there are times that it's worse than others. Consistent would indicate that once I have it, it is always there. Okay, so for example, of P1 in this one, it's a constant throbbing, deep throbbing ache, but it has a variableness to it. So I always have something. Sometimes it's worse than others. Okay? Please go ahead and get the bests, worst on the numeric pain rating scale, and then take some time to abbreviate or briefly identify the aggravating and easing factors. Now, very important that you include the timeline here, as this will help to relay some of the irritability as we plan our physical exam. All right, one other thing on the body chart, you'll notice these check marks here. In other words, up here by the head, we have the check mark that we asked this patient if they had headaches, and the answer was no. We asked this patient if they had pain in the middle region of their back, and they said no. So that falls into that asked and answered category. Here's another component of the aggravating and easing factors. Don't feel like you have to use this slide, but if there are some components of this that would be helpful, such as morning behaviors or other additional information, please feel free to use that. Your photo information should go here. This should be pretty straightforward for you. And then what I'd like for you to do is go ahead and go back to the medical screening questionnaire and go ahead and enter in their past surgical history, past medication history, and any imaging that may be pertinent to this case. All right. As you go further down the form, this is just another slide talking about sort of this incident. You know, was it an injury or did it come on over time? And you may choose to add additional information as applicable in a dropout box. Okay, when we're looking at the past medical history, again, you see this tick mark, this idea of asked and answered. In other words, we asked this patient if they had a history of diabetes or heart disease, and the answer was no. So there's a strike mark or a cross mark through this. In the areas that we do have a positive finding, you may choose to break that down a little bit further for us. Again, same thing here. As we get into some more of the special questions such as fevers, chills, sweats, etc. This is the slide that you need to spend some time on. At this point, you've completed your historical examination, and you need to clearly state what is your primary hypothesis. In other words, if you had to treat the patient now, before your physical exam, what do you think it would be? In this case, we've identified the primary hypothesis as likely to be some sort of mechanical low back pain, and at this point, probably fitting best into the stability group. Some competing hypotheses that we'll need to rule out are lumbar radiculopathy, hip OA, and possibly a primary care pathology of ankylosing spondylitis. However, it's not likely. So we might be able to plan our physical exam findings by using specific tests and measures with likelihood ratios and sensitivity specificity properties that help us to rule out these competing hypotheses, which might better allow us to rule in our primary hypothesis. All right. At this point, then, it's okay to move into the physical exam. And I really try to make it a pretty standard practice for me and certainly for my interns that we really don't touch the patient before you've been able to come up with a very clear primary and competing hypotheses. Otherwise, you really don't know what you're trying to do in the physical exam. In other words, which test measures are necessary? What are you looking for? Now, in this case, if you remember, one of our competing hypotheses was lumbar radiculopathy. And in this case, the patient had a positive slump and a positive straight leg raise at 67 degrees. So possibly that approaches that positive for the straight leg raise, for the radiculopathy. Again, no aberrant movements, no change with repeated movements. You can see here what's happening is that we're looking to rule out a particular stability category. Other areas you may look at needing to clear, feel free to summarize as best you can, just for the ease of those that are reading and listening to your cases. Again, you saw how busy that first slide of data is. Another idea might be to break it down into a table, or break it down into sections. Again, use your brain, and remember that you're going to have a lot of people looking at these, trying to identify, trying to follow your thought process here. So again, we're going to come back after the physical exam. We're going to come back and look at these hypotheses. So were we able to rule out the competing hypothesis of lumbar radiculopathy? Well, their symptoms are mechanical. The fits with the straight leg raise findings, but there's no hard root signs in this particular case. We were able to rule out hip OA, as the Altman criteria was negative for reproduction of P1 and P2. Did have some what we call local impairments, meaning that there are some things that we may need to look at in this particular patient's hip. Again, clinically, we're unable to rule out ankylosing spondylitis at this point. But again, if we're if we're unable to make expected changes, then we may choose to follow up with some MRI findings, or perhaps some lab markers. So as we're able to rule out the likelihood of these competing hypotheses, we fall back towards a mechanical low back pain. But we now identified that they have some radicular or neural irritation, and they didn't fit into the stability criteria that we were expecting. So now we have at least a little bit better idea of where to treat this patient. So they fit best into the category of manipulation, but they do have some neurologic irritation. Okay, so treatment slides. Again, I would encourage you to try to organize this in a way that's clear and concise. You don't see it on this slide, but I am going to ask that you put pre-test measurements and post-test measurements, or pre-intervention measurements and post-intervention measurements in the same slide. In my younger days, I could remember all, from prior slides to this one, but now as I've gotten a little bit older, I'm just asking that you do it for my sake and for those of your CIs that may be like me, that need to just sort of see it all in one slide. Again, at the end of the day, you may choose to sort of show your final changes compared to when you came in. And then I want you to get into the plan where really be as specific as you can on what are you planning to do next? What are you likely to see? If you're on track, if you intervene correctly, what should you see and what will you do next? That gives us a good idea that you sort of know where you're headed. Okay? So I'm not going to ask you to go through a PowerPoint presentation on every patient that you'll see during your clinical time in your internship sites. But this is the type of process, in fact, it is the process that you will complete on every single new patient exam within your facility. These are the conversations that you should be having with your CI. In other words, when you've completed the historical exam and your CI comes into the room with the patient and says, "Okay, intern, John, tell me a little bit about this patient." John, you should be, whoever you are, should be able to go to your body chart and simply state, my patient is a 35-year-old male who presents to the clinic today with a primary complaint of low back pain. He describes it as a deep throbbing ache. It's constant but variable. His best pain is a 3 out of 10, worst is a 7 out of 10. It's aggravated by, it's eased by, etc. And you should be able to move through the past surgical history. You'll be able to discuss this particular onset with your CI. No other orthopedic complaints because our body chart was otherwise cleared. Their past medical history was pertinent only for the following findings, and ultimately end up at this discussion with your CI. And your CI will then be able to ask you, okay, well, based on what you have right now with your primary and competing hypotheses, tell me what physical exam test will you use? How will you plan your physical exam? All right, so hopefully that makes sense to you. If you have some specific questions on this process, please feel free to get in touch with me. I'm more than happy to give you some specific feedback. My Twitter account is there, email, cell phone, so feel free to text or direct message, whatever works best for you in your environment. Again, I wish you well. I trust this process will be useful for you. I'd encourage you to get used to it. You're going to be using it a lot. So for now, I am going to sign off, and we'll be chatting some more soon.